Next speaker, Esteban Varela, with an ingredient to present disparities in access to basic laparoscopic surgery at U.S. academic centers from Washington University in St. Louis.
Thank you. I want to thank SAGES for the privilege of the podium to present this data. I think this topic becomes very relevant, as was one of the topics selected for the presidential debates, if you were there. So hopefully this will complement some. So we wanted to look at the disparities in access to basic laparoscopic procedures at academic centers. I have nothing to disclose relevant to this presentation. So we all know that laparoscopy has been the standard approach for different gastrointestinal procedures for almost 20 years. The disparities in access to different surgical procedures, including CABG, transplant surgery, and more recent bariatric surgery have been performed. However, there's still that needs to be known about the access for basic laparoscopic procedures. So our objective was to determine and compare the perioperative outcomes and disparities in access to two selected basic laparoscopic procedures at U.S. academic medical centers. And we hypothesized that disparities still exist at these centers. So we utilized the University Health System Consortium database, which is a very large clinical and administrative database. We selected two basic gastrointestinal procedures, which had ICD-9 procedure codes and diagnoses over a 4-year period. We selected appendectomy and cholecystectomy because they're considered basic by the ACGME if they're performed through the laparoscopic approach. We were able to identify more than 112,000 cases. So we performed univariate analysis, identified the odds of undergoing a laparoscopic versus an open procedure for the procedure studied. We stratified this data by age, gender, race, ethnicity, admission status, severity of illness, and primary payers. We performed statistical analysis using a statistical software, and P was considered significant if it was less than 0.05. So here's the data. As you would expect, most of the procedures, both for appendectomy and cholecystectomy, were performed by the laparoscopic approach, and the total of laparoscopic appendectomies was equivalent to approximately 67% of the procedures, and for laparoscopic cholecystectomy for about 80% of the procedures. As you can see also, and it has been shown by different authors, the length of stay was significantly lower for the laparoscopic group for both appendectomy and cholecystectomy, and also the morbidity associated with these procedures was significantly lower with the laparoscopic approaches. The mortality, the risk-adjusted mortality was equal or less than 1 for all procedures, meaning that all these are safe. And if you follow the upper left, this is the odds ratio to undergo a laparoscopic versus an open procedure. This is a stratification by different variables. If you see here, younger patients were 33% or more likely to undergo a laparoscopic approach for both appendectomy and cholecystectomy. Females were 79% more likely. Whites or Caucasians were 7% more likely to undergo a laparoscopic procedure. There was no difference by admission status, at least in the data that we analyzed. Patients who had minor severity of illness or were considered low risk for surgery were more likely to undergo a laparoscopic approach by 49%. And those who had private insurance or commercial compared to Medicare or Medicaid were 25% more likely to undergo a laparoscopic approach. So there's clearly still disparities. So we were trying to consider why was this, given that we know a lot about the benefits of laparoscopic approaches. As Dr. Swanstrom indicated in his presidential debate, education is very important to educate residents and fellows. It's not included here. And I included some other ones that I have seen or heard through the years. The laparoscopy is considered a cosmetic procedure that possibly could explain why younger females underwent more commonly a laparoscopic approach. There's obviously reimbursement issues. Some surgeons will think, well, if I get paid the same for a laparoscopic open, why bother when the laparoscopic setting is cumbersome at times? Most of these procedures are performed on an emergent or urgent basis. Obviously, they're performed after working hours when the laparoscopic staff has gone home, and it's more challenging to find appropriate staff to set up the equipment and find the right equipment. There has been a shift over the recent years over the emergency and trauma paradigms in patient care, and most of us that do minimally invasive surgery luckily don't take any more emergency call. That's good for us, but probably not for patient care. I often heard from trauma surgeons saying that they have obviously other acute issues to take care of, so doing an open is just quicker. It's considered by few to be more challenging and complex. It's definitely cumbersome to do a procedure in the middle of the night when you don't have the appropriate expertise, equipment, and staff available. So in conclusion, a young Caucasian female who is low risk and has private insurance is more likely to undergo a laparoscopic approach for both appendectomy and cholecystectomy. And as a final conclusion, the disparities in access to basic laparoscopic surgery in these academic medical centers do exist according to age, gender, race, severity of illness, and primary payer status. Again, I want to thank the opportunity to present this data.